simple question to start the day. Okay, so if you have this simple question to start the day, then what is important is, what is the nerve supply of the trapezius?
Spinal.
Very good. So the
Spinal
next
accessory.
question is a spinal accessory. Name an operation where it can be injured.
Modified radical neck dissection.
MRI.
Modified
Neck
radical
dissection.
neck dissection.
Radical
Again. Remember that the reason about giving this simple
Radical neck
question.
Radical.
Okay, no, it can be injured. It can be injured in a radical neck dissection. It is sacrificed. So okay, you can use these terms. The simple thing is that starting from a posterior triangle lymph node biopsy. So if you are thinking about an injury, it can be a posterior triangle lymph node biopsy in a level 5. It is sacrificed as a part of the procedure in a radical neck dissection. And you can mention that if you have mentioned neck dissection, radical neck dissection, modified radical neck dissection, well, then you have to mention what is that. So please remember that the modified radical neck dissection. Okay, so type 1, type 2, type 3 are the 3 important things to keep in mind, right? Chalo. Now, what is the type 1 MRND? What is the type 1? Hello? Come on guys, quickly, what is the type 1 MRND? Which is preserved in a type 1 MRND?
Spinal accessories.
Very good. So the spinal accessory is the only thing that is preserved. What is a type 2 MRND? Both the spinal accessory and the internal jugular vein is preserved. In a type 3 spinal accessory, internal jugular vein and the sternocleidomastoid is preserved. Now this one, so very simple question. What is the etiology of this disease? Simple question. What is the etiology that you think?
Tuberculosis.
Lymph node
Excellent.
tuberculosis.
Very good. So if it is this, then let us talk about the ulcer. What is the site of the ulcer? Anterior triangle. Now, what is the area or the picture of the surrounding skin? Hello? What is the status of the surrounding skin? So the
Increased
surrounding
pigmentation.
skin, yes, technically you may say majority of the surrounding skin is normal except for that around the ulcer, which has little amount of hyperemia, probably suggesting of an inflammatory pathology. Now, the next one is, what about the margins? What about the margins? Now, which part is the margin? If you enlarge the picture, I think you can see the margin very clearly.
Sir, well defined, sir.
A very well defined margin. So please understand, this is the reason I gave this simple question, because there is still a lot of doubt around students around which one is the margin. So this margin is technically a well defined margin. Now, what is the floor that you see? The floor is filled up with a slough. So in between the margin and the floor, obviously, the edge is looking somewhat like this, and hence you cannot see the edge.
Punched out.
No, it is not punched
Undermined.
out. It is an undermined or an inverted edge. Or it is not punched out edge, is something that will look like this. Is classical for a neuropathic ulcer, will not be seen in the neck. Remember that this one has an inverted margin. So this is very characteristic. Just imagine that this had a lymph node. Initially it was technically a lymph node, and then what happened was the lymph node underwent a caseous necrosis, as you can see, and everything came out. So won't the margin be an inverted like this that I have shown? So the margins are not inverted, edges are inverted, floor is filled up with slough. What about the base? What about the base?
Not seen.
The base is not seen, I know that, but if you are to describe for an Osce, what will you write? Sir, the base will have a minimal induration, because remember this is an inflammatory pathology, but the base is, I am interested to know that if there is an underlying lymph nodes in the neck, the ulcer is probably fixed with the underlying nodes. So when you are palpating for the base, and so equally for the sinus, that means that if this is the finger that you are using to palpate for the sinus also, remember the underlying structure is the node in the neck. So maybe that the sinus may have been fixed up with the underlying node. Okay, chalo. So this is all about the things which progress to a sinus. What stage of the disease will you call this to be? If this is a tuberculosis of the neck node, what stage will you call this to be? Hello?
Stage 4.
Stage 4. That means let us have a quick recon. What is stage 1? Stage 1 is lymphadenitis. What is stage 2?
Periodinate.
Very good. That means in a common word, it is also called as
Matting.
also matting. A nice one. Stage 3 is a caseous necrosis. Stage 4,
Collar stud abscess.
collar stud abscess. And stage 5 is technically something that you are being shown in the picture, is a rupture that leads on to development of an ulcer, and that leads on to development later of a sinus. So this is the classical 5 stages through which a tuberculosis of the neck node will progress. Okay, so please remember that. So this completes the picture, right? Now, the next one is again for an ulcer. Now, describe the clinical findings. That means, can you describe what is the site of the ulcer? What is the site of the ulcer?
Below the lateral canthus.
Very good. It is in the face, particularly. Can you mention anything? Very good, very good, very good. It is in sun exposed area below the lateral canthus of the eye. Anything more of interest in an examination? Come on, man.
Above Ogren's line.
Above Ogren's line, or what is the line that I am drawing?
Tears.
Tear line. If you read the Bailey Love, so remember that this is classically in the area of the face. You can say the Ogren's line and the tear line of the face. Okay, number 1. Number 2, now let us talk about what about the margins of the area. Oh, sorry, what about the skin? Sorry, I really missed that point. What about the skin? The skin more or less appears normal. I'm not very sure about any actinic keratosis. Hyperpigmentation maybe in this area. Okay, this area maybe, but these are all maybe actinic keratosis. Do not very sure of this. Okay, but what about the margins?
Sir, well-defined margins.
They are well-defined margins. Okay, agreed on that. What about the floor? What about the floor? Remember that if this is the margin, this is the floor.
The floor is essentially
is
smooth with little
floor is
areas,
essentially what do you
smooth
see
with
in the
little areas
no
of ulceration.
come on, man, you are describing an ulcer, so how can the floor again have an ulcer? What do you get to see in the floor of this ulcer?
Granulation tissue.
Very good. Floor is filled up with minimum amount of a granulation tissue, but please write the word minimal amount of granulation tissue. What I'm more interested is that if you had said some amount of a scarring in the floor, okay, because there is little amount of scarring and granulation tissue in the floor. Now tell me, what about the edge of this? This is the classical edge.
Punched out edge.
No, sir.
Rolled
no,
out.
sir.
Rolled out. Beaded.
Rolled out.
This
Rolled
very
out.
good. So this is the classical appearance of something in which understand that Yes, that this is the rolled out edge of a basal cell cancer. So this is the classic rolled out edge of a basal cell cancer. So please remember that. So you saw a tuberculosis with an inverted edge. You saw a basal cell cancer with not an inverted edge but a rolled out edge. So this is what you are asked. Now, in a viva question, examiners would have asked you, what is the difference between a squamous cell cancer and a basal cell cancer? Now remember that both of them are non-melanoma skin malignancies. A basal cell cancer, what is important is the basic biology difference is that after it grows, the ulcer only penetrates deeper. So the only thing that it will do is that the cancer, as you can see in the picture that I have drawn, the basic biology is that the cancer is going to grow in deeper. The cancer grows in deeper like this. So if the cancer is growing in deeper like this, it is going to invade the tissue. But there is also associated intense desmoplasia in a basal cell cancer. Always remember that. Basal cell cancers are associated with intense desmoplasia. Now, this intense desmoplasia is said to block or choke the lymphatics. And hence, what is the telltale sign that is absent from a basal cell cancer?
Lymph nodes.
What is very good?
Lymph nodes.
Remember that squamous cell cancers invade nodes very quickly. This one does not invade nodes because of two reasons. The reason number one is an intense desmoplasia that occurs around the growing edge or the growing base of the ulcer. Number two, the cells of these are extremely large in size. So if they are so large, how can they travel through lymphatics? Now, this is the reason it tries to grow in and is called as a rodent ulcer. It is called as a rodent ulcer. Okay, right. So done. Now the next part is, on the other hand, if you think about a squamous cell, the squamous cell, remember, has a rapid growth phase. So in a basal cell, it has only a vertical growth phase. We talk like the word in a melanoma, whereas in a squamous cell, the basic biology is that it starts exactly like a basal cell, and a basal cell had initially started maybe as a nodule, and then the nodule grows in deeper. So if you understand this one, that this is also a part of a nodule, and this nodule gradually grows both in vertical as well as horizontal planes. So that means the main emphasis is there is a horizontal phase and there is a vertical phase. Now, in a squamous cell cancer, definitely the horizontal phase predominates rather than the vertical phase. And hence, if you see about the central part, obviously will undergo a necrosis because it cannot get the food. And while it cannot get the food, and this part then technically becomes somewhat like this because it is trying to grow. So this tumor, as you can see in the picture, is trying to grow out. So please remember that a squamous cell cancer, what is the age in a squamous cell cancer?
Everted.
Very good. So I hope you have now understood today why does a squamous cell cancer have an everted edge. Please remember that. Now, the depth of infiltration and the involvement of underlying tissues will always be there, agreed. But remember that before this, what is very important is the involvement of the lymph nodes, because they are richly supplied, and that means they will also have a lymphatics, and lymph node metastasis is a common phenomenon. So this completes what is about a basal cell cancer. Now, the treatment of a basal cell cancer, remember, is not wide local excision. Please remember, squamous cell cancers are treated by a wide local excision with about varying margins, about 1 centimeter on an average. A basal cell cancer, what is the treatment of choice, or what is the nature of surgery? What is the nature of surgery for a basal cell cancer?
Wide local excision.
No, sir. This is the reason I told you. You do not go for a wide local excision in a basal cell cancer. Why not? Array, I told you, na.
Because
What
lymph node spread
microscopic
is not
surgery?
Okay, now tell me, doctor, why don't you go for a wide local excision in a basal cell cancer?
because it is not spreading. It is
Because what is the type of growth that I told you?
Vertical
Vertical or
growth.
what? Yes, it is more of a vertical growth. So if it is more of a vertical growth, why should you be worried with a wide local? Wide local is taken because you are more interested about the peritumoral lymphatic spread in the stomach. Why do you take a 5 centimeter, 6 centimeter margin? Because you knew there would be spread in the submucosa lymphatics. So in a squamous cell cancer, the thing that you are seeing is the tip of the iceberg, and hence your technique of excision has to be somewhat like this. But in a basal cell cancer, the main issue is about growing it into the depth, and hence a excision of the tumor with a margin being negative, and hence the role of a Mohs micrographic surgery has come in a big way in this point. Okay, so this completes this part. Now we come to the next question on the mammographic abnormality. I think that this question was a very straightforward, but let us see how many of you wrote. Now, what are the points that you write in any mammography? Number one is that what is the view? The view is a right mediolateral oblique that has been written. Okay, so the number one point that you have written is the view. Okay, now so mediolateral oblique. The next point is that you have all defined what are the points to define. Number two is that if you have mentioned that there is a vague lump in the breast, then what are the margins and what is the architectural distortion? Like if you see that the margins definitely are not ill defined, but there is no architectural distortion. Architectural distortion is technically not very appreciated. More or less the breast parenchyma appears to have a good architectural pattern. Now, after we have talked about, now talk about the next important thing, that is this. What are these things that are being shown?
Microcalcification.
microcalcification.
Okay, good. An undergraduate, I would have given him or her maximum marks, but for a
Clustered
postgraduate,
pleomorphic multiple.
excellent. This is what I was wanting. Please see these ones. These microcalcifications are clustered as well as of various sizes and various shape. Now, sizes doesn't mean the micro becomes macro. They are all called micro because they are of a size of around less than 3 millimeter in a various way. But remember that these are all clustered microcalcifications, which goes more in favor of which pathology?
Malignancy.
Okay, malignancy. Can you be more specific? They will go more in favor of and DCIS. And if you have thought about a DCIS, now can you comment upon how much is the extent of the DCIS in the specimen? Hello? Can you see that the DCIS is extending technically, or these clustered microcalcifications are extending more or less very widely? Okay, but definitely with one view, it will be impossible to comment upon what is the extent of the DCIS. But remember, that will be one of the important factors when you are deciding for a breast conservation surgery. The next of the things to decide after you have talked about the microcalcifications is talk about the nipple areola complex, talk about the pectoralis major whose border is very clearly shown, and sometimes even the axillary nodes and the condition of the skin is commented. So let us have a review. What is the view? What is the margin of the lesion? What is the architectural distortion? The presence of any calcification, nipple areola complex, skin, and the pectoralis major. So you are not required to comment in your exams about something called BIRADS, because we are not a radiologist, we are not going to score this. But if you are so intent upon talking about a BIRAD, what is the probable BIRAD in this patient? What is the probable BIRADs?
4B.
4.
Okay. Wow, good. I do not know about 4A, 4B, 4C, but I will be commenting either it is a BIRAD 4 or a BIRAD 5. This is what I will be commenting. Either it is a BIRAD 4 or a BIRAD 5. Okay. And what is the next intervention that you will always do in this patient?
True
Sir,
cut
core
biopsy.
Very good. I will go for a corneal
Corneal
biopsy. Very nice. Okay. Right. So this completes the first part. I'm really impressed with your knowledge. Talk about this one. This is the more advanced one. Talk about this one. This is the. What is this?
Ultrasonography.
Ultrasonography. Very good, sir. Very good. Anything that is beyond an ultra.
Elastography.
Excellent. Very good. So that means, what is this one? This is technically called as an ultrasonography or an ultrasound elastography. So this is called as an ultrasound elastography. Okay. Now, in this one, so the question has been very straight. In an ultrasound elastography, what is the advantage of adding an elastographic principle to the ultrasound? Try to understand the question. What is the advantage of adding an elastographic principle to the ultrasound? Anyone kindly answer this one? Or what is the principle of use of elastography? What is the principle of use of elastography, sir? Hello?
So determine the amount of fibrous tissue in the.
Okay.
Determine the invasiveness.
Invasiveness. Okay, right, sir.
Sir, hardness of the tissue.
Excellent. So this is what the examiner is wanting to hear, is about the hardness of the tissue. That means in the breast tissue, which one do you think is the most or softest structure that can be deformed and it can quickly come back to the shape that it was before?
Sir, fat.
Definitely fat. And which one will be the hardest of the tissues that if you put a stress or put a strain, it is going to get deformed and it is not going to come back? That is going to be a malignant tissue. So definitely remember that if you think over in a elastographic world, in an elastography, the basic idea is that fat is soft and cancer is very stiff. So if fat is soft and cancer is very stiff, a fibrous tissue definitely will inch more close towards this point, whereas the normal parenchyma of the breast will go more in towards the fat side. Now, what this thing does is that a elastography is usually done either in a dynamic. So the radiologist will use these words. They will use a word called as a dynamic, and they will use a word called as a static. Okay. And what they will do is that they are going to have the measurement of, so the basic idea is something that you have understood now. So in a real time ultrasound with an elastography, what the radiologist is going to talk about is technically about the size of the lesion and technically about the stiffness of the lesion. So the size of the lesion and technically the stiffness of the lesion. So very basic things that we should know. Okay. Now when you talk about the size of the lesion, now there is a very important ratio that is to be important. Now what is important is, think over that if we did not do an ultrasound, now think over, if we did not do an ultrasound, okay, that now understand a very important thing. Can you see this tissue? Oh, sorry. Okay, in this picture, can you see the tissue? Oh, sorry, the pathology. Hello. Can you see the pathology?
Yes, sir.
What will be the ultrasonographic interpretation of this one?
Hypoechoic lesion.
Very good. What about the margin, sir?
Well defined.
Not well defined, sir.
Not
Can
well
you see that?
defined yet.
Not well defined, and can you
Not
see
well
that the margins are irregular?
Irregular, yes, sir.
Is it an homogeneous or is it an heterogeneous appearance?
Heterogeneous, sir.
Heterogeneous appearance. Very good, sir. And that means now, see, there is a measurement. Say, for example, the measurement is, say, 4 centimeter. So I'm just guessing. Maybe 4 centimeter is the measurement. This is the maximum size. Now, the parallel picture, picture number B, is you apply some elastographic principles and these elastographic things that are shown by these color codings. Okay, it looks like the Doppler code like thing. Now, when you do this color coding, can you see that how much is this green and this tissue is extending?
Yes,
Can you
sir.
see that? Okay. That means that this green and this tissue for them, for the radiologists, they basically, that means their color coding thing means whatever is the elasticity of the tissue, the color of the tissue takes that color. That means if you consider that the blue is the normal fibrous parenchyma of the breast, and now consider that this so-called this green orange thing is a cancer, appreciate that the measurement number X and measurement number Y in this very simple picture, which one is more, X or Y?
Why, sir?
Very good. That means if this ratio Y greater than X, that means the size of the lesion on an elastographic picture is more than that of the real time image on an ultrasonographic scan. Remember that is going to suggest you this thing to be more of a cancer. Or people say that if the ratio is greater than 1, so initially it was 4, now it is also 4. The ratio is 1 or less than 1. But if initially the size is 4, but the elastographic appearance tells you to be 10, definitely. So 10 divided by 4 is more than 1. So understand that the bottom line thing is that on elastography, the size is more. Okay. Please remember that the basic idea is that, so the size increases because there is a surrounding desmoplasia of the cancer. So if you do a core needle biopsy, every one of you have done a core, you know what is desmoplasia, and the stiffness of the tissue reflects that only. So that is called as a elastographic first principle. The second is something that is more difficult for us as surgeons to understand, is something called as the stiffness, which is now measured by radiologists according to their various parameters that they will do, in which you are not required to know that, but for your MCH exams, just remember a name called as the Tsukuba scoring system. The T is silent. It is called as SUKUBA. The Tsukuba scoring system is something in which it is technically the color thing that I have shown you is technically something called as the Tsukuba scoring system. And this is what majority of people will use for their color coding and to make the surgeon understand that what is what into this one. Okay, so this is the first part of the thing that you are required to know. The only point, if you are interested to know, is please remember the name. I do not know how many of you will be able to remember the name at the end of the class. It is called as a Tsukuba scoring system. How many points are there in BIRAD? How many points are there in BIRAD?
6.
6. That means BIRAD 0, BIRAD 1, BIRAD 2, BIRAD 3, BIRAD 4, BIRAD 5, and BIRAD 6. Okay, right. Now, if that is so, remember that in the Tsukuba scoring system, more or less looks like a BIRAD. The score starts from 1, which means the tissue is very elastic. Tell me, guys, if the tissue is very elastic, deformable, is it good or is it bad?
Good, sir.
Good. That means it is not cancer. If the score is 5, that means it is very stiff. That means, what do you think is this thing then?
Favor of malignancy.
In favor of malignancy. Now the patient has a cyst in the breast, benign cyst in the breast. Which one do you think will it be? Cyst contains water. More towards 1 or more towards 5?
More towards 1.
1.
Very good. More towards 1. Because as I have said, these are usually this one. So good. So that means you have understood this one. It took me many years to understand what is an elastography. Have you understood what is elastography and what is the color coding system that is used in elastography?
Sir, is there any particular indication for this when we do it?
No. Well. Good one. Good. Very good question. I was expecting this one. Now, doctor, at end of the day, see, we are surgeons. Okay. At the end of the day, the bottom line for us is that in a triple assessment, you did a clinical followed by radiology. After the radiology, what is the decision that you take? After the radiology, what is the decision that you take? Whether to go for a biopsy, yes or no, isn't it?
Yes, sir.
Right. Now, what is the thing that, see, we surgeons, we are not interested with this understanding mammography, okay, magnifying the picture. I'm least interested. There is only one word that I am interested with. That is called as BIRADS. We surgeons are least interested with elastography and all these things. We are not interested. The only thing that we are interested is BIRADS. Now, ultrasound, remember that mammography came first, and thus if you see the American College of Radiology, which has coined this term BIRADS, the mammography atlas is in its 10th or the 11th. I've forgotten which one is it. It is the 10th or the 11th edition. But if you think over with an ultrasound, something that is very commonly called as a sonomammogram. Have you heard the word sonomammogram? Sonomammogram. Now, it is not combining ultrasound with a mammography. It is the improving the technique of an ultrasound to match the outcome or a specificity of a mammography. Now, for a BIRAD on an ultrasound, the edition is still in the 5th edition. So that means they are still lagging behind. So to increase the specificity of the test, that means it is a cancer, it is a complementary addition that your radiologist is going to do. So that means if it was a BIRAD 3, maybe after they did the ultrasound elastography, it can be upstaged to a BIRAD 4B or the vice versa. Have you understood the point?
Yes, sir. Thank you, sir.
Okay, right. So this is a new concept. So please understand that your questions in future or your NEET SS questions, see, ultrasound is something that you read in your undergraduate days. So there is nothing great. Every one of you know about an ultrasound of the breast. Elastography is something that you can be asked in a long case also if you are doing good. So please remember that a radiologist who is confused with an ultrasound, he or she will add something called as an elastographic principle. Okay. And what is the name of the scoring? What is the name of that scoring system that I told you? Let me see how many of. Wow,
Tsukuba.
good man.
Tsukuba.
Tsukuba. Okay, good one. So you can change your WhatsApp DP to this one. Good. That's it. So good one. So now you remember this one. Another.